All right, guys. So for this lecture, we're going to try to finish up the rest of the structures inside of the respiratory system, specifically everything from the pharynx on down. So we're going to kind of get started into this. So just below the pharynx, we have this little section referred to as your larynx, which more commonly is referred to as the voice box. Its main purpose is to either route air into the trachea or route food into the esophagus. It does play a little bit of a role in speech because this is also where our vocal cords are housed. And it's made up of kind of this rigid hyaline cartilage. Has kind of a spoon-shaped flap that sits over the top of it, which is referred to as the epiglottis. But you can kind of see down here in this diagram that's at the bottom, this is the opening to the trachea, and then this is the opening to the esophagus. The epiglottis is this little piece that sits over the top. So when you swallow food or water or anything else that should go down your esophagus, that clamps down over the top so to protect not only the vocal cords but keep things from going into the esophagus, the trachea itself, so then it can kind of get routed into the esophagus here. If you take out this section, the larynx, which sometimes has to happen because people get cancer or other type of damage to this portion, they would not have the ability to speak. People that have a trachea, an external trachea, stomata, they call it sometimes, is an opening or a hole that's been placed in the anterior portion of the throat right over the top of this, essentially bypasses this section. So air no longer actually goes through that. It actually goes through that stomata. That's why sometimes people have to have those electronic voice boxes to be able to give themselves a voice because they're not passing air through their vocal cords at that point. But this is kind of what you see here. Epiglottis at the top, trachea opening below it, and then esophagus opening right next to it, okay? I'm going to embed this video in the portion of the lecture, so don't worry about trying to go through this, but it shows you a little bit of kind of the movement of the basic larynx. Other structures we see in here then, so obviously we have some other cartilage. We have what's referred to as thyroid cartilage. It's the largest of all the hyaline cartilage we have in our body, and it protrudes kind of anteriorly in this kind of ring-shaped structure, which we often refer to as our Adam's apple. Men usually have a much larger Adam's apple than women, and it has mostly to do with the effect of testosterone on this cartilage. The other portion then we already kind of mentioned a little bit is the epiglottis. So this is just a flap of elastic cartilage that sits over the top of the larynx. It's right above, so it's superior to the larynx, and then its main purpose again is to route either food or air depending on the direction that we want this to go. But if I go back, actually, we can see it in this one. This is one of the reasons why we want to make sure that we cut food up for little kids, because this opening is really small in between here and they can kind of get caught. Okay. The other structures we see here in the larynx are the vocal cords themselves. And really what they're doing is they're just a piece of cartilage, an elastic material that essentially vibrates as air is expelled across the top of it to give us our voice. All right. The other opening then is just the middle portion of this is what's called the glottis. That's the opening between the vocal cords. And the vocal cords will actually open and close depending on the sound that we need to kind of get out of them. Okay. Other structures then, so once we get past the larynx itself, we get into the trachea. So the trachea essentially is the connection between the larynx and the bronchi. It's actually lined with ciliated mucosa. And the cilia actually beats in the opposite direction of the incoming air. So the air is moving from essentially the nasal or oral cavity down into the trachea, and that cilia beats in this opposite direction. And it does that for a couple different reasons. It's mostly doing that to get any particles that would have made its way through the nose or mouth, dust, pollen, dirt, debris, and try to expel those up towards the esophagus so we could essentially either swallow them and get them into our stomach, or we could spit them out as essentially mucus or phlegm from the top of there. The other thing that we see in the trachea itself is that it's actually reinforced with C-shaped cartilage, so it's open on the back side, but the cartilage is kind of C in nature, so it kind of has that basic shape. From there, we get into kind of the bronchi. So these are the divisions of the trachea. So these are the first structures they actually reach after they get from the trachea. So it goes trachea, bronchi, and then we'll get into some of the divisions of those. They enter essentially the lungs on both sides in what are called a hilus. Hilus are just kind of these little curved depressions on both sides of the lungs. And then the right bronchi is actually wider and shorter than the left bronchi. And it really has to do with the station of the heart. So the heart's kind of, remember, tipped a little bit to the left. So the right bronchi has more room to kind of get into the lung than the left bronchi. All right. Lungs themselves, again, I'll kind of post this video a little bit for you guys. So they occupy pretty much all of the thoracic cavity except for the portion of the heart. The apex is pretty much right at about the clavicle portion, so that's the upper portion. The base rests pretty much right across the bottom of the diaphragm. That's why they have that little bit of a curvature to the bottom of the lungs. The lungs are actually divided into lobes by these little pieces called fissures. And the lobes are a little bit different. So the left lung has 2 lobes, all right? You can see a basic upper and lower lobe. And the right lung actually has 3 lobes. And that's mostly because the right lung sits pretty much right over the top of where the liver is. And because the liver takes up a little bit more space in the abdominal cavity, forcing up into the thoracic cavity, the right lung tends to be just a little bit shorter and have this extra lobe to it. Okay. You can see their position here in the cavity itself. So here's posterior cavity, vertebral column back here. Here would be sternum up here in the front. You can see some of the ribs across the sides on both sides. And then here would be the right lung, left lung over here on this side. And you can see it's kind of positioning in to the heart. So these are the pulmonary veins kind of coming back to the heart, and then these are the bronchi over here on this side. You can see the pulmonary arteries kind of going out that direction as well. Right. Just like any other organ that we've talked about so far this year, the heart has its own coverings. All right. So there is a pulmonary visceral pleura. So the visceral pleura is that which would directly attach to the surface of the lung. And then we have a parietal pleura, which is which lines the cavity. So there's a fluid-filled space in between the two that allows the lungs to essentially glide without rubbing on anything. But there are conditions where people can have that you can get that rubbing. So if they get a condition called pleurisy, all right, pleurisy is where we have an infection of that lining or infection of that fluid. And essentially what happens when people have pleurisy is their lungs actually rub either on the outer wall, or that fluid itself is causing pressure down on the lungs. So every time they breathe, they get this kind of sharp sensation of their lung actually rubbing on something. It can be kind of painful. You can actually hear it on a stethoscope. So when they take a breath, you can hear this kind of rubbing, like saran wrap being rubbed between your fingers, kind of sensation as the lungs kind of expand and deflate there. Okay. The rest of the respiratory division trees look like this. This is one of those questions that most often shows up on the assessment. So make sure you take a look at this one and kind of know them. So we have our primary bronchi. All right. So we have a right and left primary bronchi. That's the main branch off the trachea. Secondary bronchi are the next branch from those. So they branch off into a couple smaller portions of those. We have a tertiary bronchi, which is essentially the ending of those. And then from there on out, we have the bronchioli. So those are the small little fine branches that lead into the alveoli, so the terminal bronchi. Those are our basic branches there. The smallest of the branches are the bronchioles, all right? That leads into our alveoli, our kind of air sacs. These branches don't have any reinforcing cartilage in them, which is why sometimes, especially with people who are asthmatic, these branches can actually close. They're more muscular than they are kind of held open by cartilage. And they can kind of deflate and kind of close off, and then it becomes very hard to breathe because of that kind of contraction of the muscle tissue around them. Right? Skipping just a little bit. Sorry, guys. I'll go back. Terminal ends then are the alveoli. So these are these little air sacs here at the end. And that's actually the portion of our respiratory zone, remember. So the conducting zone is everything to get us to here. Once we get to the alveolar sacs, we are now respiratory zone. So those are the structures that we have in there. So the respiratory or bronchial, the alveolar duct itself, so the duct that leads away from the bronchiole, and then the alveolar, which is just the sacs here at the end. And the main reason we refer to this as the respiratory zone is because this is the site of gas exchange. So gas is going to move from in the alveoli to the blood, and from the blood back into the alveoli. The main thing we really want to see happen is oxygen move from the alveoli to the bloodstream, and carbon dioxide move the opposite direction. And this mostly happens by simple diffusion. When you breathe in, the air in your lung would have more oxygen in it than what's in the bloodstream, and the bloodstream should have more CO2 in it than what's in the lung. So they should exchange places because of that. All right. Structures of the alveoli. So then we have the alveolar duct, the sac, and then the alveolus itself, which is just the opening at the very end. All right. And again, just like I mentioned before, this is where gas exchange takes place. And this is the big thing to remember. This is simple diffusion that's allowing this to take place. All right. Higher concentration, lower concentration. Higher concentration of oxygen in the alveolus. All right. Lower concentration of oxygen in the capillary. Higher concentration of CO2 in the capillary, lower concentration of CO2 in the alveolus. All right, they'll move directions, or should move directions, because of that. Okay. All right, we're going to go ahead and stop there. I'll kind of cover a couple of those things at the beginning of class, probably tomorrow. But I'll make sure I post those couple of videos that we were in there as well, so you guys can take a look at those.